This series of slides is meant to prepare you for lab this week. So we'll go through the background before doing the details on Thursday, which is before everybody's lab. So spirometry is what we are looking at in lab this week. And just as a brief review, I want to take a moment to make sure that you're all up to speed, we're all on the same page about the respiratory physiology info that we talked about last week. So what factors affect gas diffusion? What makes the lung the ideal site of gas exchange in the body? We talked about three main things.
Surface area.
Surface area is high or low?
High.
High surface area.
Thin membrane.
Membrane is
Thin.
thin membrane. Thin barrier for diffusion. And a pressure gradient. A pressure gradient, we like it to be large. It's pretty much set, but there's a cascade that allows air, specifically oxygen as a gas, to move from the environment inside the body to be loaded into the blood. All of those factors make up, in large part, Fick's law of diffusion. There's also the solubility constant in there, but we identified that we don't care about it so much because it doesn't change. It's constant. What about regional differences within the lung? We talked about the ventilation-perfusion ratio at length. So maybe give me a sense of how each of those change as you move from the base to the apex of the lung. So ventilation, alveolar ventilation, the amount of air reaching the alveoli, base versus apex.
At the apex, it's not as much ventilation.
Okay.
As we go down, it increases.
Excellent. Higher alveolar ventilation near the base, lower near the apex. What about flow or perfusion?
Perfusion increases the same way.
Perfusion increases the same way. Fantastic. Both are lower near the base. If they're both lower near the base, does that mean the ventilation-perfusion ratio doesn't change? If they both increase in the same way, they both go up as you go down within the lung, they're not changing differently from the sound of it. So does the ventilation-perfusion ratio change? If it does, how does it change? Both are higher near the bottom, near the base of the lung. Both are lower near the apex. How does the ventilation-perfusion ratio change?
The base is greater than 1.
The base is greater than 1. What else could it be? It's not greater than 1. It's actually less than 1. Yeah. It's a good guess. There's only two ways to go with it. It's less than 1. It's lower at the base because perfusion increases more. They both increase as you head towards the bottom of the lung, but perfusion increases more. Denominator is larger. Fraction or ratio is smaller. Usually less than 1. And the opposite is true. Higher than 1 near the apex. And you could almost think of it as gravity might exert more of an effect on blood flow, being that it's a substance, it's a liquid, it has mass, so maybe it increases more because of those effects of gravity that we talked about last week. And regulation of ventilation was the last section. What was the main driver of ventilation and or the main sensor that created the signal to drive ventilation? Talk to me about those quickly.
PCO2 in the bloodstream.
Okay, PCO2 is the first step in the process. If we have a higher PCO2, something happens to make ventilation go up. What comes next?
It washed over the hypothalamus. There's sensors in there, centralized sensors, and then there's also peripheral sensors in the aorta.
Okay, fantastic. Yeah, so the hypothalamus can sense the blood directly. PCO2 has an integral role in stimulating ventilation. But there was a really interesting slide that I put on at the end with those weird exercise intensities that might suggest, if not specifically PCO2, but something else. And what was related to PCO2?
The pH.
The pH. So if you have an increase in PCO2 that's buffered to release bicarbonate and a proton. The pH, the increase in protons or the decrease in pH is what we largely think is the driving stimulus for the brain to increase ventilation. And specifically, the central chemoreceptors respond to that signal. The peripheral chemoreceptors usually respond or adjust that signal in response to a change in PO2. But it's relatively small. 20% of the signal to breathe might come from the peripheral chemoreceptors, and usually only in situations where O2 is lacking. PCO2 causing an increase in the hydrogen ion content or a decrease in pH is largely the reason the central chemoreceptors stimulate ventilation. Good. Let's move on. What is this section about? Knowing how the lungs function properly, we want to look at how they might function improperly or not function properly. The candidate condition we're looking at is COPD, chronic obstructive pulmonary disease, for which there is no cure. It's irreversible. We'll talk about the progression of the disease and what this means, how it comes to pass. We'll take a look at how we diagnose COPD and other respiratory conditions using spirometry that you will use in lab. You've probably done something like this before, but rather than using the fixed mechanical bell spirometers like I think you used in anatomy and physiology, we're using the METCART, which is maybe not any more accurate, but nicer that you don't have to breathe out of that contained space with who knows how many bacterial cultures. So we're going to talk about how we use these things. We don't know what FVC, FEV1, MVV are yet. You might remember that they are acronyms for something, but we'll talk about what they are and how we use them to diagnose COPD and other conditions. Those will be brief, though. Sleep apnea and asthma, we'll talk about those briefly as a way to contrast how these variables might change in those different situations, but the principle is generally the same. COPD is our main candidate disease, though. And I don't actually know if we need to talk about this. I still have this in the slides, but I took this portion out of the lab manual. We could do it together as a group in class if we wanted to, but an illustration of the control of ventilation using breath-holding procedures. We'll talk about what how we can modify the ability to hold our breath and what signals we would create that might stimulate the drive to breathe. We can collect some data on it as well. That might not be a part. We'll see how much time we have. So let's talk about COPD, chronic obstructive pulmonary disease. And I generally like starting when we introduce a new disease with sort of the scope of the disease. Where are we currently in our community, the province, Canada at large? Before adding the lab component, we would do a new disease almost every week, and so we went through a lot of these scope type slides, but we don't do that as much now because there's a lot more functional material. But as far as COPD is concerned, it's quite prevalent. And so I've thrown numbers up here for diabetes, type 2 diabetes, and I'll show you some stats on both the incidence of COPD and diabetes, just to contrast them. And the reason that I chose diabetes is it's a popular chronic condition. We've heard about it endlessly. You might know people that are afflicted with type 2 diabetes or type 1 even. But we have a general sense of how prevalent diabetes is, and at least by the numbers I've listed here, COPD is as prevalent, if not more, in North America. It's so prevalent, there's a fairly significant portion of deaths resulting from COPD. 3 million people die of COPD annually, or 5% of deaths, both in the US and in Canada, which is a large proportion of deaths. It's a large proportion when you look at the percentages of the other mortality causes in that region. That region being third, fourth, fifth leading cause of death. In the States, it's currently the third leading cause, resulting in 5% of all deaths. The top two are pretty big, usually cancer and cardiovascular disease. In Canada, it's fourth, and we'll see that on the next slide. Canada, it's fourth, but just by a narrow margin. At least in 2016, it was fourth when I got these numbers. And the reason COPD is so prevalent is by the aggravation of airways, largely due to smoking. So the primary cause of COPD is any exposure to tobacco smoke. Primary or secondary exposure. First-hand or second-hand smoke. By far the leading cause, but not the only cause. Any other irritant can also stimulate symptoms of COPD or progress the disease further. So as we live increasingly in urban areas, highly industrialized urban areas, air pollution can play a role. Exposure to chemicals at your job, if you're in an industrial type role. And there's some role for respiratory infections as a child that make you more susceptible to these irritants as an adult. That might increase the prevalence of COPD as well. Again, not curable. This is a cumulative effect. As these accumulate, the disease progresses and it can't be reversed. So don't ever smoke. Hopefully it's not too late for you. So let's take a look at the Canadian statistics. These are the most recent that I could find. The CAN-SIM tables from 2014. We have numbers from 2016 about the leading causes of death. Wait, do we? I mentioned 2016 for the states on the last slide. That's where I'm getting confused. These are the most recent Canadian numbers, and you can see COPD, chronic lower respiratory diseases listed here at number 4, with only 12,000 deaths per annum in 2014. Seems like a small percentage, about 5%, but again, in relation to the other diseases nearby, not very small, quite large. It's only dwarfed by cancer and heart disease, number 1 and 2 in Canada. So about 5% of individuals will die of COPD. This is not the individuals that have COPD. This is only deaths. It's not incidents. I'll show you incidents shortly. One question arising from these numbers might be, I say it's big, but is it big? And how is it changing? Is 5% or 4.6 rather, is that static? It seems low. We hope it decreases, but it's actually going up, or it has been going up over the last 60, 70 years. Here's a breakdown of the average incidence, both sexes in red, the average mortality rate or percent of total deaths due to COPD. Notice it's approaching that 4.6 mark. That matches what we saw on the last slide. And then broken down by sexes, men and women, a slightly higher incidence in men overall. Sorry, I'm using incidence flippantly. A higher death rate or mortality rate over time in men, but a faster acceleration in women over recent years, which is notable. We think that's largely due to increased industrialization and women taking up smoking, popularly in the 70s-ish. Just think of Mad Men, smoking in the offices and on planes. The reason that it might have been higher in men initially could be previous exposure, occupational hazards, working in coal mines, etc. It's not the Industrial Revolution, which was early to mid-1800s, but largely the increase overall is attributed to the increase in the popularity of smoking from the 50s onwards. So there's an acceleration, and we see this convergence. Everyone matches around 4.6, but these are still old data. This is 2010, 8 years ago, almost 9. We don't have more recent evidence or information than 2014, but it's been stable since then. It's been stable around 4.6, below 4%, since 2010, and hopefully even decreasing since then. So this is a depiction of the incidence rates of COPD, not death rate, not mortality rate, incidence rate. So notice the number of persons much, much larger than we saw on the last slide. Canada-wide, 12,000 deaths. Canada-wide, the incidence rate is in the 800,000s. Okay, large incidence rates, much larger. And this is a comparison that I really like to do of Canada overall, our province, and then progressively drill down to Pictou County. This is what I best approximate as Antigonish, so our local incidence rates of COPD. Again, diabetes as a comparator, just because we have a sense of how prevalent it should be. And there's a few things that I think we should notice. Number one, impressively high or shockingly high incidence versus diabetes. So in all of these 3 major sections, Canada-wide, in the province, or locally, incidence of COPD somewhat lower, but still generally approximates that of diabetes. So fairly high incidence rates relative to diabetes. It's not winning by any means. There's no winners in this case, but higher than you might expect. Number 2, I would say, is the trend that we exhibit for almost every chronic condition you can look at, which is unfortunate for us living here. The trend is incidence rates for COPD lower at the national level, higher within the province, and highest locally. Same occurs for diabetes if you're looking at the non-highlighted numbers. COPD, cancer. The flip side is true for fruit and vegetable intake, fiber intake, physical activity. We're in a pretty bad pocket as far as overall health is concerned. Yeah.
What is that percent? Like 4% of what? Of everybody or
of the population?
of the population?
Yeah, the percent is of the population. So incidence number versus percent of the population in that area.
So that like when for Nova Scotia, it'd be 5.9% of the province, not of the local.
Right. Yes, of the province.
Do you have anything to say about why 2012 to 2013 there's like almost a 4.6% drop? Is that just a lot of people with COPD died?
That's a good question. Is it that a lot of people with COPD died? Without those numbers, I can't say for sure. It's not possible to tell what the normal variance should be. We don't have error bars or anything to base this off of, and the data locally is tenuous. These superscript E's mean caution the data set is not complete. It could just be a large swing in the number of reported cases or the people that reported with COPD or were treated for COPD or sought help from their doctor. Maybe fewer people sought help here, so we're not recording them in the population at large. I don't know why it dropped so much and then went back up. I don't have a clear answer, no. Which brings me to my next point that might undermine it a bit, but I was going to say it was generally stable over 5 years. Locally, it's not so stable in 2013, but generally, in the larger community, it's generally stable over 5 years, which is good, I would say. We'll asterisk that good, though. And lastly, what's not so obvious is the incidence rates are similar to the mortality rates. And I can't draw concrete conclusions about how many people die each year due to the incidence, but on average, it seems that if these match, that implies that there's no reversal, there's no cure, which we know there is no cure for COPD. So the people that develop it are likely, if it's severe enough, to die from complications associated with COPD. So the incidence rate here is similar to the mortality rate that we saw on the last few slides. So interesting. COPD as a disease, let's see. So acceleration largely due to an increased smoking rate, popularized in the 70s until the anti-smoking campaigns of the late 90s and early 2000s. Also generally an increase as the population ages, as those individuals that have smoked for a long period of time develop increasing symptoms. The prevalence of COPD increases with age, as with many diseases. If you give a disease enough time to present, it will. And it seems, luckily it seems that the rates have stabilized, but until recently it seemed that women were at specific risk just from the dramatic increase in smoking rates and incidence of COPD. They were catching up too quickly to the high incidence rates or mortality rates that men exhibited, largely due to increase in affluence, high-income countries, the luxuries associated with that, the increased prevalence of smoking, and gender equality. Not something that you want to be equal in, though, because there's no cure. We'll talk about why there's no cure coming up right now. One thing that's not on here that I mentioned initially, respiratory infections in childhood can increase the likelihood of getting or developing COPD. Respiratory infections in adulthood similarly can increase the likelihood of COPD. They don't progress the symptoms, but they make you more susceptible, if that makes sense. The infection doesn't cause COPD, but it makes you more susceptible to irritants in the environment. So we've talked at length about what COPD not is, but the prevalence of COPD, and we've thrown the acronym around. Let's now talk about what it is. Chronic obstructive pulmonary disease or disorder. Generally, this is a combination of two conditions, bronchitis and emphysema, which you can see highlighted here. Bronchitis on the top, emphysema on the bottom. These are ever-present and accumulate over time, hence the chronic. They are obstructive, mostly because of bronchitis. It represents a block in airway flow. There's an obstruction to airflow through the bronchi, perhaps through the smaller airways as well to the alveolus. Chronic bronchitis represents a block in airway flow. So for the same effort of inspiration, less air moves. Cross-sectional area is smaller. It increases the resistance to flow. I'll have more information on this specifically coming up as we talk about each of these in depth. And then emphysema, separate from chronic bronchitis, but often associated in presenting with these other conditions, represents a breakdown of the tissue of the lung. So the elastic tissue in the alveolar buds or the alveoli themselves, a breakdown in the alveolar sacs, usually means a decrease in surface area. It looks like we have larger or swollen alveoli, but that's just because the elastic tissue has broken down and can't contain them. They might seem to swell beyond their natural size. Or they might not be well-defined pockets or bulbs like they are in a healthy lung. It looks like they're bulging because there aren't as many connective walls between the alveoli and the alveolar sac. So blocked airways and a breakdown of elastic tissue. In general, the progression is as follows. We've already identified that something has to aggravate the situation. Smoking, pollutants, CFCs from aerosol cans, pollution from urban centers. something irritates and inflames the airways, and what the mechanisms are or where in the lungs that occurs is not really the focus, just that they are irritated is what's important. The irritation largely causes some corrective measures. The lungs will respond initially by trying to protect themselves with a covering of mucus to prevent the irritants from damaging the epithelium further, which would normally be a nice protective response, except that the increased production of mucus causes the airways to narrow. So we have our first initial acute appearance of bronchitis as the airways narrow due to an increased production of mucus. This will continue while the irritant is present. It stays within the bronchi, the trachea, smaller airways. It accumulates in the alveolar sacs and eventually can cause breakdown of some of the fibrous tissue. Not to mention, this isn't a 100% effective countermeasure. The aggravating agents can still cause inflammation in the airways that compound the narrowing of the airways. Which is why in a lot of cases, you'll hear people talk about smoker's coughs, this persistent, wet, hacking cough, trying to get the sputum, mucus, out of the alveolar sacs, out of the lungs, as it's constantly being produced as a countermeasure for the irritation caused by whatever the aggravating agents happen to be. And so narrowing from mucus production and inflammation, breakdown of elastic tissue from aggravating agents, and the buildup of mucus and sputum lead to bronchitis and emphysema. Yeah?
How does the sputum break down the fibrous tissue?
That's a good question. I don't actually know the specific mechanism for how it breaks down the connective tissue. I was just thinking of that as I was presenting it, and I want to know more about it to give you that answer, but I can't give you that answer right now. I'm not sure what it was that causes
the
the...
regularly present in the lungs, anyways, correct?
Regularly present, but not in these quantities.
Okay.
And perhaps it's the quantity or the type. If the agent does something to modify the production, it could be that the newly formed sputum causes breakdown. I'm not exactly sure how.
And the sputum will like absorb the
Usually.
inhalant? Yeah.
Usually,
Okay.
yeah.
It doesn't just like reflect it.
No. No. It's a good question. And I'd love to know more about the mechanisms involved, but we're really concerned about the functional aspects of it. If we assume this is the pathophysiology, and this is the end point as far as what the characteristics of the lung are, how does that limit function? That's where we're going with it, and I want to know more about the pathways and the biochemistry, but I don't right now. Question? Are you good?
I was just gonna ask the same.
Something
thing,
similar?
If like the inhalant was actually trapped in the sputum, if that had
Yeah.
anything to do with the breakdown of the fibrous tissue in the alveolar sacs, because maybe it would be,
My inclination is yes,
yeah.
but I can't say that with certainty. That's my inclination. Very good questions. You guys are sharp. So let's talk about it functionally. We'll return back to this diagram briefly. Progression of COPD as exhibited here in the successful loading of oxygen into the blood. We've already talked about this at length. This is transit time and then the time it takes for PO2 to move from the alveolus into the blood. Normally we have successful, easy loading of oxygen into the arterial blood. You can think of these as a spectrum, so progressing from normal to abnormal to grossly abnormal would parallel the increased prevalence of COPD. There might even be a situation here in the middle with mild symptoms, someone that doesn't have full-blown COPD or a quote-unquote smoker's cough, that has mild exposure in their younger years to irritants or infrequent exposure to inhalants, smoking, etc. Mild symptoms might present. Overall, the progression here means incomplete gas transfer. So incomplete loading of O2, incomplete offloading of CO2, resulting in hypoxia and hypercapnia, right? Low PO2 in the blood, high PCO2 in the blood. Those are important as we look at the treatments for severe COPD. So with mild symptoms, and let's call this intense exercise. With mild symptoms, maybe you only exhibit intolerance at really high exercise intensities. Normally we can exercise at high intensities just fine with full loading of oxygen. Maybe with mild symptoms you only exhibit intolerance to intense exercise, and more moderate type exercises are not a real problem. You still have full onloading of oxygen with a somewhat reduced transit time. So exercise intolerance at high intensities might be one of the first indications of symptoms. As COPD progresses, well, clearly, we'll call this the abnormal trace now. Clearly, exercise intolerance is not only evident at high intensities, but also at moderate intensities as we have significantly impaired oxygen loading into the arterial blood. In the most severe cases where COPD has progressed fully, the grossly abnormal trace, we have rest intolerance. We don't even have full loading of oxygen in the arterial blood at rest with normal transit time. And this is where we need supplemental oxygen to help force the loading of oxygen into the arterial blood. That's the gas canister with the nose tubes that you typically think of when you think of perhaps an older person sitting in a chair, walking around, taking the cart around. The symptoms of COPD are severe, and they're not getting full loading of oxygen into the arterial blood at rest. So a little bit more information on these two factors. I already talked about them, and you probably have a good idea of what they mean, but bronchitis, the swelling illustrated here, decreases the cross-sectional area. So if we want to get the same alveolar ventilation, what needs to happen? We have a blockage, an obstruction. Flow is reduced. Alveolar ventilation would be reduced. What would we do or need to do if we wanted to maintain alveolar ventilation?
Increase frequency, right?
Increase the frequency. Possibly. But let's think, if there's a blockage which prevents movement of air to or past that blockage, if we increase the frequency, we might just recycle the air up to the blockage more frequently. It's not a bad idea because that's one of the main ways that we increase ventilation. The other one being tidal volume. In general terms, we have to just contract more forcefully. We have to try to accelerate the air more quickly. We need a higher velocity airflow to move the same amount of air. We need a more forceful inspiration to move the air past the blockage. And that could be more frequent. But it needs to be a more frequent and more forceful movement of air. So the opposition to airflow is increased. We need a higher pressure to achieve the same flow, or a higher pressure gradient to achieve the same flow. We would do that by creating a lower pressure in the lungs, a larger negative pressure to pull air in, which generally means more forceful contraction. The work of breathing increases. There's a large scientific contingent looking at work of breathing in COPD and how work of breathing is really an untenable situation, increased work of breathing. Imagine the extreme case. So we have a blockage here that's partial. Imagine a pinhole, right? At some point there won't be any flow, but if you have just the smallest airflow, think of the type of inspiration or the contraction of the respiratory muscles that you would need to force air through a small fixture like that. And then draw the line from that to what the normal situation is with the large cross-sectional area. Somewhere in the middle we have compromised flow, increased opposition, and gradually we need to do more work of breathing to move the same amount of air. Overall, compromised alveolar ventilation if we don't do that. And the spoiler is we don't do that. Yeah?
The sputum, will it move as you breathe in? Or is it like kind of like plaque and it kind
Ooh.
of more fixed?
Great question. Will it move?
Just thinking like
Will
if you
it
were to
move?
keep breathing hard enough, would it eventually pile in one region? And
I think it should move, and then if the irritants accumulate in the sputum and cause changes to the sputum itself, which make it more viscous or more plaque-like, I think it will slow down. I would imagine it's something like a spectrum, where over time, the inflammation and the narrowing of the airways from accumulation of the sputum here would be more static. That's how I imagine it, and that would make sense, but again, I'm not exactly sure. That's a great question. Yeah.
So, though there's no cure, is there treatment to like remove sputum or like do people ever get transplants
Yes.
and stuff?
Yes. And we'll look at that shortly. Steroids are a good one to help open up the lungs. You can cut out some of the dead tissue of the lung. In extreme cases, full transplants. Yeah, there are therapies to help correct it, but not correct. There are surgeries to circumvent COPD, but there's nothing that can correct or reverse the symptoms of COPD. Emphysema, on the other hand, we think in functional terms, in the breakdown of the elastic walls of the tissue, breakdown of the alveolar sacs. The loss of fibrous connective tissue makes the walls more flimsy. During inspiration, it's not so much of a concern because we're creating negative pressure in the pleural cavity. We're trying to inflate the lungs. We're inflating the alveolar sacs. But as we switch from inspiration to expiration, without this fibrous support, the small airways specifically can be pinched off. So if we have a normal alveolar duct here with these ridges of fibrous elastic tissue that support the structure of that tube, they remain rigid, they don't flex, they're compliant, but they don't close. Here we see on the right-hand side with the lung exhibiting emphysema, the small airway, the duct, collapses. As the pressure builds in the pleural cavity, it closes off that airway. Now, not all of the air will have been expelled from the alveolar sac. It's now trapped by that alveolar duct being compressed and being blocked off. So we have a double-edged sword where the breakdown of elastic tissue causes the collapse of these arteries, or allows the collapse of these arteries. And then with the increased pressure as we breathe out, the air trapped in here can cause further rupture and further damage to the already tenuous connections between the alveoli and the alveolar sac. Not to mention, as those walls break down, there's less surface area for gas exchange. And we also see downstream effects on blood flow in the capillaries. They are intimately related to the alveolar sacs here. These, being pressurized during the exhale, can then pinch off flow in the capillaries. That zone 1 respiration that we talked about that doesn't happen normally within the lung might occur. On the lower right-hand side, the alveolus here, if it's pressurized, can supersede the pressures on the arterial and the venous sides and block off flow in that artery. So we can have downstream effects compromising perfusion as well as ventilation, because this is air that's not being renewed because it's not going back to the environment. It's being trapped within the alveolar sacs.
When you're saying the exhalation of the air, is that due to, let's say, thoracic cavity going back to its normal shape, or is it like the conscious effort of exhaling?
So, okay, the question is if when I'm talking about exhaling, is it passive relaxing or is it active contracting of the respiratory muscles to push out air? I think it can be either, because in both cases, pressure increases. Even if it's passive relaxing, the recoil of the respiratory muscles increases the pressure less than if you're forcing air out, but it still increases the pressure in the pleural cavity. And you don't need a lot of pressure to pinch off these wobbly noodles. The alveolar ducts are very non-rigid in this situation. So even a small increase in pressure can obstruct, maybe not completely block airflow in that situation, but significantly obstruct escape of air from the alveolus. I would say either. So let's take a look at a video quickly that goes over this, helps with some of the context. It shows you all of this happening in real time as an animation, and it talks a little bit about the treatments that Leanne asked about a second ago. I'm not sure how the audio from the surrounding speakers will record, but we'll give it a try. See what happens.
Chronic obstructive pulmonary disease, or COPD, is the gradual loss of your ability to breathe effectively. Normally, as you inhale, air moves freely through your trachea or windpipe, then through large tubes called bronchi, smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Small blood vessels called capillaries surround your alveoli. Oxygen from the air you breathe passes into your capillaries. Then carbon dioxide from your body passes out of your capillaries into your alveoli so that your lungs can get rid of it when you exhale. Normally, your airways and alveoli are flexible and springy. When you inhale, each air sac inflates like a small balloon. And when you exhale, the sacs deflate. Smoking is the leading cause of COPD. However, it may also be caused by long-term exposure to other lung irritants, such as air pollution, chemical fumes, and dust. If you have COPD, you have the two main conditions that make up the disease: emphysema and chronic bronchitis. In emphysema, your airways and air sacs lose their flexibility, making it harder for them to expand and contract. Emphysema destroys some of your air sac walls, leading to fewer, larger sacs that provide less area to absorb oxygen from the air you breathe. The symptoms of emphysema include wheezing, shortness of breath, and tightness in your chest. With chronic bronchitis, damage inside your airways causes the lining to swell, thicken, and make mucus. You develop a persistent cough as your body attempts to get rid of the extra mucus. The symptoms of chronic bronchitis include an ongoing cough that produces a lot of mucus, shortness of breath, and frequent respiratory infections. The damage done to your lungs by COPD cannot be reversed, and there is no cure for the disease. However, treatment can slow the progress of your disease and help you feel better. The most common treatments are quitting smoking, use of inhaled medicines to open your airways and reduce swelling, antibiotics for bronchitis caused by bacterial infection, oxygen therapy for those with advanced COPD and severely low levels of oxygen in their blood, and surgery, such as a valectomy or lung volume reduction surgery to remove non-functioning air sacs. The best way to prevent yourself from getting COPD is to never smoke. If you are a smoker, quitting smoking reduces the chance you'll develop COPD. You can also limit your exposure to chemicals, fumes, and dusts that may cause COPD.
All right, so nothing new. The learning grows from repetition, right? Also, I really like that for the animations to give you a bit of context, because you can imagine the alveoli and the capillaries normally. Maybe you have what the picture is in your mind, but that really helps put it into context, I think, and the difference between normal and abnormal is illustrated nicely there. So that's where we'll leave our discussion on COPD, but I do want to introduce a couple other conditions briefly before on Thursday we talk about how to diagnose using spirometry and then the factors we talked about before. So we can diagnose it. There are clear differences in airflow for COPD. Clear differences in the velocity of air, the amount of air through the airways, and spirometry is what we can use to figure that out or observe that directly. Now, similar to COPD, irritants can cause, or a secondary effect of COPD can be sleep apnea, where the loss of elastic tissues, if it progresses further to the upper respiratory tract and then the throat, can cause the airways to collapse while sleeping, which we'll look back when we get to the next section on cardiovascular physiology and we start talking about ECGs, but has a significant impact on pulmonary hypertension. It can cause you to stop breathing overnight. Some people will wake up hundreds of times in the night because of this effect here as the epiglottis closes the airways at the back of the lung, at the back of the head. The common way around this is to use constant positive airway pressure. So to inflate the lungs artificially, which essentially makes more air move for the same amount of effort. It's not unlike oxygen therapy, except oxygen therapy in advanced COPD cases is not a sealed, pressurized treatment. It's just passive delivery of oxygen. It actually wouldn't be a bad treatment to use constant positive airway pressure in COPD. I'm not sure why a lot of people don't do that. But sleep apnea results in many of the same effects as COPD because of the reduced transfer of air, hypercapnia and hypoxia. I would normally ask this, but we already went through these items at the start, and you guys are pretty on point. And the treatment, as far as constant positive airway pressure is concerned, is simply to always provide a pressure higher than what the environment will provide. Constant positive airway pressure. And that simply serves to inflate the lungs, increase the pressure gradient, keeping the lungs inflated and driving gas transfer, oxygen transfer into the blood specifically. And here's a situation where it might be a bit more obvious that the treatment should be, I would ask this normally, but I think you can read it in one of the small text boxes. To increase the total amount of ventilation, either whole body minute ventilation or alveolar ventilation, constant positive airway pressure targets specifically tidal volume, not frequency, to increase the delivery of air to the end point in the lungs. It avoids hyperventilation, for one, and we'll see what that entails on the next slide. And it decreases the work of breathing, the frequent contractions and recoiling of the respiratory muscles as you breathe in and out. Overall, both of those factors help to improve alveolar or whole body minute ventilation. Pressure gradient, decreased work of breathing. Now we'd like to avoid hyperventilation, like we'd like to avoid COPD, because both of those examples of abnormal breathing can affect downstream systems in the body, specifically here, acid-base balance. So if we start from a normal point, right in the middle, with a neutral pH, typically around 7.4, not exactly 7, but 7.4, where our body likes to be. And we modify our breathing patterns. We can move within this scale, usually left or right along the pH scale. We'll talk about COPD first, and I'll illustrate how hyperventilation would give the opposite change. But in COPD, we observe increased resistance to airflow, incomplete delivery of oxygenated air to the alveoli, resulting in hypoxia and hypercapnia. CO2, again, is central to this through the same mechanism that we regulate ventilation. So hypercapnia with COPD means more CO2, means more CO2 is buffered, means more bicarb and hydrogen ions are produced. So we have an immediate decrease in pH. An immediate decrease in pH. We slide along this curve towards the left. An immediate decrease in pH, what we call respiratory acidosis. Notice it's not simply to the left, it's not horizontally to the left, it's also up, which in this diagram means there's an increase in plasma bicarb as well. And that's simply a result of the dissociation of CO2 plus water, CO3, into bicarb and hydrogen ions. We have an immediate leftward shift, which causes a decrease in pH and a small increase in bicarb. Remember, pH is measured simply by the concentration of protons, so we don't like when body tissues are acidic. Normally what we would do is regulate through ventilation, blow off that excess CO2 and return this equation towards the left. But in COPD, we can't do that. We can't ventilate more because of the obstruction, because of the decreased surface area. And so we're left in this acidotic state until renal compensation kicks in. Renal compensation is the increased production of bicarbonate to combine with and offset the increase in hydrogen ions. We never fully return to normal. We might end up at a pH of 7.3, 7.35 with a much larger circulating concentration of bicarbonate. And this is where people with COPD often find themselves. Unable to compensate through respiration because ventilation can't increase. So renal compensation is required, increasing circulating bicarbonate to buffer the increased hydrogen ions. We don't want to treat sleep apnea, for instance, with an increase in frequency because that would increase or cause hyperventilation. That's the opposite end of the spectrum. If we were ever to hyperventilate, breathe more frequently, generally to disperse CO2 to the environment, we enter into a situation called respiratory alkalosis. We remove CO2 from the environment. We pull the equation at the top here towards the left. We reduce the protons in circulation. Fewer protons in circulation means higher pH, a more basic environment. Question about that?
Do people ever go into like kidney failure because of like the renal overcompensation?
Do COPD patients specifically ever go into kidney failure?
Yeah, like because of like the kidneys having to kick in over time.
The answer has to be yes, but I think they're in the minority. If their symptoms ever progress that far, the complications associated with COPD are much more likely to cause death than kidney failure. But the answer has to be right. Like it has to be yes. Some people would have to, because of the increased work of the kidneys to produce bicarbonate, would have to see some negative side effects. I think COPD in that case is by far more progressed and more severe than the small extra work by the kidneys. So normally if we hyperventilate, we would try to compensate through not breathing as much. That's why you often see people put a brown paper bag over the mouth of someone that's hyperventilating to trap the CO2. If you're excessively losing CO2 to the environment and causing alkalosis, you want to trap that CO2 to prevent that increase in pH. But if you can't do that through respiratory avenues, the opposite kind of compensation occurs at the kidney, where we increase the excretion of bicarbonate at the kidneys, returning pH back to normal. This is a fairly complicated diagram. I just want to make sure that that made sense. There's a lot of off-slide talking. I saw a lot of furious note-taking. You'll have the video to go back through. But did that all make sense? The most important part is that we can't correct through respiratory avenues for patients with COPD, and so we need to correct through renal compensation.
Just like looking at the graph, like, where do you start? Just because like.
Where do you start?
Like where would you consider normal, or like that shifts up to COPD?
You start in the middle. You start wherever the normal person begins. And here it's an arbitrary value of, or there isn't really an arbitrary value. An arbitrary 7.4, which we know is normal in the body. And then here we have different levels of bicarbonate circulating, or sorry, CO2, PCO2 within the blood. So 40 millimeters of mercury is normal. A pH of 7.4 is normal. If a COPD patient can't ventilate as much, they trap CO2. Here we see PCO2 of 60. And I should have brought those in as we went through the discussion. Higher PCO2, hypercapnia, and then compensation by the kidneys to increase bicarbonate by sliding up that response curve. Start in the middle with the normal values, 40 millimeters of mercury and a pH of 7.4. All right, let's do one more video and then we'll call it for the day. This is to introduce spirometry as a practice, what it entails, how it's set up, what it measures. Okay?
Diagnosis and evaluation of chronic obstructive pulmonary disease, COPD. Early detection of COPD is essential for those who may be at risk. Once the disease is diagnosed, treatment can be started that can slow down or help prevent further damage from occurring to the lungs. An ongoing cough with mucus production is often an early sign of COPD. Daily coughing is not normal and could be the sign of serious lung conditions. Individuals who have a history of smoking or repeated exposure to lung irritants should ask their healthcare professional for a breathing test called spirometry to determine if the symptoms they are experiencing are due to COPD. The earlier COPD is diagnosed, the better for patient outcomes. Once COPD is identified, there are effective medications that can help patients do more and can help lower the chances of having COPD flares or acute exacerbations of COPD. If prevented from progressing, patients with a mild stage of COPD can live a fairly normal life. Patients with moderate to severe stages of COPD have a greater risk to their health and worse outcomes than those who are diagnosed with milder forms of the disease. In mild cases of COPD, respiratory systems may not be recognized or may not be very troublesome. These individuals may be unaware they have COPD because people may mistakenly think that their cough is just a smoker's cough. The fact is, there is no such thing as a normal smoker's cough. Others with COPD may feel tired and experience uncomfortable breathing during physical activities. As a result, they stop being as active. These feelings of fatigue and trouble with activities may be due to COPD. If an early diagnosis is confirmed, patients will be able to receive the appropriate medical care to reduce the progression of the disease and its symptoms. Take a look at these patients. Can you tell which ones, if any, have COPD? Many people, even many healthcare professionals, believe that you can tell who has COPD based on their symptoms, risk factors, physical examination, and appearance. But this is a myth. The reality is that a breathing test, or lung function test called spirometry, is required to diagnose anyone with COPD. There are many other conditions that can be confused with COPD. People who have trouble breathing and have a cough may have COPD, but they may have other conditions like heart failure, scarring of the lungs, called fibrosis, asthma, or other breathing problems instead of COPD. This is why it is essential for you to get a breathing test, called spirometry, to be sure that your symptoms are due to COPD and not because of another condition. Based on your symptoms, your exposures to smoke and other lung irritants, and your medical history, your healthcare provider may order a breathing test called spirometry, which may also be called a lung function test or a pulmonary function test. During spirometry, you will be asked to take a deep breath and then exhale as hard and as fast as you can into a tube that is connected to a machine called a spirometer. This test measures how much air you can breathe out and how fast you blow air out. This test is simple, quick, painless, and accurate. Spirometry can predict COPD before symptoms are noticed or recognized. How fast air exits the lungs within the first second is called the forced expiratory volume, or FEV1, and indicates how well your lungs work or function. The spirometer allows your healthcare provider to compare your results against healthy individuals of similar age, height, gender, and ethnicity. In patients who already have COPD, spirometry is helpful to monitor changes in lung function, especially if done a month or two after a lung attack, also known as a COPD flare or an acute exacerbation of COPD.
We'll leave it there. And I like this because you can see the norms. These numbers will make a lot more sense as we go through the lab and then the lecture on Thursday. And again, learning grows from repetition. What's the lung test called? What's the breathing test called? Yeah, they said it like 8 times. That's good. Okay, we'll leave it there for today. We'll talk about how we specifically diagnose COPD with these numbers. We'll talk about what these numbers mean, and then the procedure for lab Thursday afternoon.